This conference will now be recorded.
Started కదా. Good morning, all of you. Are you able to hear
Good
me
morning,
and
ma'am.
see the PowerPoint?
Yes, ma'am.
Okay, so I'll start. What was our last class? What did we study?
Pulmonary hypertension.
Okay, did you read anything about it? Okay, fine. Whenever you get time, or like you just revise, because they are very simple at your level, which you can remember for entrance exam also. So that is the thing about pulmonary hypertension. And now we'll see about adult immunization. See, usually whenever immunization comes, see, how many of you are present now? Some 84 members. You stop putting the attendance. You can give me the attendance once after the class is over. Okay, I'm not taking very long classes also, as we have done live classes, so you can put it after the class. Okay, so for now stop the attendance and listen. See, whenever immunization, we talk about immunization, we'll be thinking in terms of pediatric immunization, right from the birth, whatever we give and all. So those all will be dealt in the pediatric classes. Now we are talking about the adult immunization. Do you think like adult immunization is important? Why is it important? Why is it like we need to give adult immunization when there is pediatric immunization or immunization of the newborn or neonate? Is it important or not, adult immunization?
Yes, ma'am.
Why? Okay, good that it is important, because see, in the early ages we are having low immunity, or I mean our immune system is not trained in the younger ages, so we are giving the pediatric immunization to fight against the diseases. In the same way, in the adult circumstances also, where we are immune compromised, either because of age progression. See, at the extremes of age, the patients are people are usually vulnerable to infections and all, because the immune mechanisms are not those are not that strong enough as they are in their middle age to tackle the infections and everything. So adult immunization, either it might be because of just age related, or like a hypo when splenectomy has happened, or certain conditions where the normal mechanism is deranged, either because of chemotherapy, whatever, all these things, or HIV, where immune mechanism is like is taken back, or like which is not acting as good as like it has to be working in their middle age. So we deal with adult immunization in those circumstances. So what is the adult immunization we give? Immunization is the process by which an individual becomes immune or resistant against a agent, which is known as immunogen. Immunization can be achieved in an active or a passive manner. Vaccination is an active form of immunization. Okay, so active immunization is nothing but you are just giving an antigen. Whenever antigen is given, the antibody mechanism is produced against an antigen. So our body is producing the antibody, that is active immunization. Passive immunization is nothing but you are transferring an antibody to a patient. Whenever you're giving an antibody to a patient, it means that he is not producing it, he is getting it from outside. that is passive immunization. So transfer of immunoglobulins in case of GB syndrome or myasthenia gravis, all this where we give IVIG or immunoglobulins per se subcutaneous or IV, those all are coming under passive immunization. See, difference is like your body has to produce inactive immunization, so it takes time. Whereas passive immunization, it's not like your body is producing, which are produced already outside the body. So it acts. I don't compare because both the mechanism are different, but it has a quick, immediate action. So, next, vaccinations are recommended throughout the life to prevent infections, disease, and their sequelae. Vaccines are crucial to prevent mortality in more than 25% of death are due to infections. Adult immunization, which is built on success of childhood and adolescent immunization program. If not vaccinated earlier, the booster should be not vaccinated, you should be taking the boosters. New vaccines targeted at the adults. When the aging process occur, the patients or people are more susceptible because um, as age progresses, I told you, either because of the R mechanism, our body innate mechanism, where the immune responses are not that great working as that middle age, because middle age is the time where all the requirement for the immune system is present, like either it might be vitamins, minerals, everything which is required by the immune system are intact. As the age progress, there are deficiencies. Whenever there is deficiency, you tend to have you tend to have like more prone or more immune system which is weak. When it is weak, it is not able to kill the bacteria or whatever it is which is entering the body. So recognition of burden of adult vaccine preventable disease. So these are the things which adult immunization is built on. So the you see, whenever a patient is aging, or and he is having pneumonia, or splenectomy is done, or if chemotherapy is there, all these are the things which will lead you to vaccinate. The usual vaccines which are listed in the adult immunization program are Haemophilus influenza type B vaccine, hepatitis A and B, hepatitis B vaccine, human papilloma virus vaccine, influenza vaccine, which are of 3 types: inactivated, live attenuated, recombinant, measles, mumps, and rubella vaccine, meningococcal serogroup B vaccine, pneumococcal 13 valent conjugated vaccine, pneumococcal 23 valent polysaccharide vaccine, tetanus, diphtheria, toxoids, DPT, and acellular pertussis vaccine, varicella vaccine, zoster vaccine, recombinant, and as well as live. These are the ones which are included, which is not like you can't remember like this, but you will remember in the schedule. We'll come. Okay, we'll. No, I didn't ask you to put attendance. Why are you keeping? If the people are entering right now, they might not know what I told before. But previous class, I did tell you not to put the attendance in between the class. So remember that. See, this is usually adult immunization. We have categorized into 5 categories, like 19 to 21 years, 22 to 26 years, 27 to 49. This is the middle age, um, and where immune systems are okay. All these cases, immune systems are intact. 50 to 64 years and more than 60 years. It is where more immunocompromisation is occurring. Okay. See, I told you not to put the attendance again, you people are doing the same. So first coming, which is the most required, or the vaccine which we give most cases? Influenza, because influenza is pandemics, epidemics, everything are more common. influenza inactivated and recombinant, or live attenuated. Both are present. Both of them can be given in these age groups as one dose annually. Every year you can give a single dose. Okay. And DPT or TDAP, both are the same. That is diphtheria, tetanus, and pertussis. You give one dose of TDAP and then a booster every 10 years. It means that first dose which you are giving is working for a period of 10 years in producing an effective antibody response. But you want to get the similar effective response, you give the booster every 10 years. Okay, then MMR, one or two doses depending on the indication. You give it. This is at 19 years to like around 55 years. Okay. Then coming to varicella. Varicella, you give two doses if born in 1980 or later. Okay. And then zoster, recombinant, and live vaccines, which you usually give at the age of 50 to beyond later years of life. Okay. If you are giving recombinant, you can give it as such in the elderly population. But if you are giving a live vaccine, it is a single dose. And then HPV, uh, you give HPV vaccine for both male and female. If it is a female, you give 2 to 3 doses depending on the age at initial vaccination. And if it is male, you give in 19 to 21 years. So okay, if it is female, 19 to 26 years. If it is male, 19 to 21 years. Okay. Then pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine. You give them one dose. And pneumococcal polysaccharide vaccine. What is the difference between a conjugate and a polysaccharide? Microbiology, do you have immunization special, any class on immunization? I suppose you should be having. So only I asked. Any answer?
Yes.
Yeah. What is that? You can put in the chat box. If it is like you can't say. Next, hepatitis A. Hepatitis A, you give like 2 to 3 doses depending on the vaccine. Meningococcal ACWY. These are the ones which are having the vaccine. These strains of meningococcus. You give 1 or 2 doses depending on the indication, and then you give a booster every 5 years if the risk remains the same. And then meningococcal B vaccine, you give 2 to 3 doses. ACWY are 1 to 2 doses, whereas this is 2 to 3 doses, depending on the vaccine and indication. And Haemophilus influenza type B, 1 or 3 doses, depending on the indication. Okay, we will now discuss in detail about all these. The first one, influenza vaccine. Only on immunization and not specifically on. I didn't get you. You mean the class? Okay, okay. In the microbiology class, they are only told about. See, immunization, they told you in the sense immunization mechanisms are dealt, right? I also asked about the immunization mechanism only, types of immune responses for the vaccinations, or like different types of vaccines and all. Those are dealt in microbiology. Now we are dealing about the practical aspects of that one. These are practical aspects. Mechanisms and all you will be knowing in your first 2 years, these paraclinical subjects. Now you have to put that into practice. So now what all we say, just we include mechanism or pathology, pathophysiology for us to understand it better. But whatever the mechanism of everything we are learning in medicine has already been dealt either in your pathology, pharmacology, everything, etc. So this is something clinical, more of clinical. So you will get these pathology mechanisms in easier way in your microbiology textbooks or pathology, etc. Okay. Now, anyways, we will discuss everything. First, coming to influenza vaccination, trivalent trivalent inactivated influenza vaccine and live attenuated influenza vaccine and influenza recombinant vaccine are available for use in adults. And routine vaccination, persons, people aging 6 months or older, you give one dose of inactivated vaccine or recombinant or live attenuated vaccine appropriate for the age and health status annually. As we discussed already, for influenza, every year you give a vaccine. And the special situation where there is egg allergy, hives, etc., you give one dose of IIV, RIV, or LAIV appropriate for age and health status annually and check for the reactions. If egg allergy is more severe than hives, if hives only, that is the thing. If it is like more severe than hives, like you are developing an angioedema, respiratory distress, then you give one dose of IIV, RAV, LAIV appropriate for annually in medical setting under supervision of healthcare provider who can recognize and manage the severe allergic conditions. Immunocompromised conditions including HIV infection, anatomical or functional asplenia, pregnant women, close contacts and caregivers or severely immunocompromised persons in protected environment, use of influenza antiviral medication in previous 48 hours with CSF leak or cochlear implant, then you give one dose of IIV, RIV annually. Live attenuated is not recommended. You should be knowing that in immunocompromisation, wherever it is, whenever there is immune system compromised, then you are not supposed to give live vaccines. Always prefer recombinant or inactivated vaccines or killed vaccines. And then coming to history of GB syndrome, within 6 weeks of previous dose of influenza vaccine, you should not be vaccinated again. See, GB syndrome uh, uh, is a kind of ascending paralysis starting at the lower limbs. It can involve the respiratory system also, and it can cause the patient to be crippled and can be bedridden. If it involves the respiratory system where the respiratory capacity everything compromised, death can happen too. So that is GB syndrome, and one of the cause of GB syndrome is influenza vaccination. So whenever the patient, because of influenza vaccine, develops GB syndrome, you are not supposed to be vaccinating the person again with influenza. Other causes of GB syndrome are Campylobacter infections and all. But as we are dealing with influenza, now we talked about influenza. That is first one. The second one is measles, mumps, and rubella vaccine (MMR). It is a routine vaccination done. There is no evidence of immunity to measles, mumps, or rubella. In case, if at all the patient doesn't have, then you give one dose of MMR. So usually you give the MMR vaccine to a patient in the early ages, like 9 months, etc., like in the pediatric schedule. Now you give the patient an MMR vaccine in adults. You know that there is no immunity, means he is not previously infected or he is not taken any of the vaccine and their boosters. So evidence of immunity. How can you say there is immunity born before 1957, except healthcare personnel, and documentation of receipt of MMR, lab in evidence of immunity or disease. See, those people 1957 before, those people are everyone is vaccinated uh, right now because it is in our schedule. So those people are more immune because that was like that occurred as an exanthem at that period of time where immunity has developed. And then special situations like pregnancy with no evidence of immunity to rubella. MMR is contraindicated during pregnancy because rubella, which is which can cause brain defects in case of uh, fetus. After pregnancy, before discharge from the healthcare facility, you can give 1 dose of MMR. Non-pregnant women of childbearing age with no evidence of immunity to rubella, you can give 1 dose of MMR. HIV infection with CD4 count more than 200 for at least 6 months, and there is no evidence of immunity to measles, mumps, or rubella. There you give 2 series of MMR for at least 4 weeks apart, and MMR is contraindicated in HIV infection with CD4 count of less than 200. So see, if the CD4 count less than 200, don't go for these vaccination. Severely immunocompromised conditions, MMR is contraindicated. Students in post-secondary educational institution, because those are the people more susceptible as the exam progresses. International travelers and household or close personal contacts of immunocompromised patients with no evidence of immunity to measles, mumps, or rubella, you give them 1 dose of MMR if previously received 1 dose or 2 doses of series MMR at least 4 weeks apart if previously did not receive any MMR. Then healthcare personnel born in 1957 or later with no evidence of immunity to measles, mumps, or rubella. Then you give them two dose series of MMR at least 4 weeks apart for measles or mumps, or at least 1 dose MMR for rubella. If born before 1957, consider 2 doses of series of MMR at least 4 weeks apart for measles or mumps, or 1 dose of MMR for rubella. See, because that there were changes before and later. 1957. Then coming to TDP, tetanus, diphtheria, pertussis vaccination. It is a routine vaccination. Previously did not receive, if the patient did not receive TDAP at or after age of 11 years, then you give him 1 dose of TDAP and then TD booster every 10 years. Okay. In special situations, previously who did not receive primary vaccination series for tetanus, diphtheria, and pertussis, then you give 1 dose of TDAP followed by 1 dose of TD at least 4 weeks after TDAP and another dose of TD 6 to 12 months after last TD. TD boosters are given 10 years thereafter. In pregnancy, there is you give 1 dose of TDAP during each pregnancy, preferably in the early part of gestation, gestational weeks 27 to 36 weeks. So usually DPT is the one we considered, but usually what we give is tetanus vaccine separately. Then Haemophilus influenza type B vaccination. First one we talked about influenza vaccination. Now we are talking about Hib vaccination. Haemophilus influenza type A bacteria. And in the special circumstances, whenever there is either functional asplenia, anatomical or functional asplenia, including the sickle cell disease, then you give 1 dose of Haemophilus influenza B if previously did not receive Hib, or if elective splenectomy is planned, then you give 1 dose, preferably at least 14 days before splenectomy is done. Okay, 14 days for its mechanism to be uh, acting. And hematopoietic stem cell transplant, in that you give 3 doses series of hip vaccination, which are 4 weeks apart, starting at 6 to 12 months after successful transplant, and then regardless of hip vaccination history. Next vaccination is meningococcal vaccination, and special situations like in anatomical or functional asplenia, including sickle cell, HIV infection, persistent complement component deficiency, then eculizumab use. Then you give 2 doses, 2-dose series of meningococcal ACWY, Minactra or Menavir, at least 8 weeks apart, and revaccinated every 5 years if the risk remains. See, for before we talked about Haemophilus and meningococcal, both of them are capsulated organisms. Because of that, in splenectomy, the capsulated organisms can cause infection. So, in case of splenectomy or functional water, when the spleen is not there, you have to give Haemophilus and meningococcal vaccination. If travel in countries with hyperendemic or endemic meningococcal disease, microbiologists routinely exposed to Neisseria meningitis. Then you can take like 1 dose of meningococcal ACWI and revaccinate every 5 years if risk remains the same. First year college student who live in residential housing, if not previously vaccinated at the age of 16 or older, and military recruits, then you give 1 dose of meningococcal ACWI. Now this is a special situation for meningococcal B vaccine. Anatomical or functional asplenia, then you are including sickle cell disease. There you give persistent complement component deficiency. Whenever there is component deficiency, sickle cell anemia, eculizumab use, microbiologist in exposed to Neisseria meningitis, then you give 2-dose series of meningococcal B4C, Bexero, at least 1 month apart, and 3-dose series of meningococcal B, FHBP, Trumanda, at 0, 1 to 2, 6 months, and meningococcal B4C and meningococcal B FHBP are not interchangeable. Both are different. In case of pregnancy, delayed meningococcal B until after pregnancy, because during the time of pregnancy it is contraindicated as there is increased risk of fetal disease. So as vaccination will cause potential risk, we are not supposed to give during pregnancy. The only thing which we give in pregnancy is tetanus toxoid. We can give DPT, but see, usually what we follow is tetanus toxoid. Healthy adolescents and young adults during age of 16 to 23 years, age of 16 throughout 18 years preferred, who are not at risk of meningococcal disease, then you give based on the individual clinical decision, may receive either 2 doses of series of meningococcal B4C at least 1 month apart, or 2-dose series of meningococcal B FHBP at 0 6 months. Meningococcal B4C and B FHBP are not interchangeable. It means that you can't give one for the. In the strain, these are substrains like that. In meningococcal B is different from that meningococcal ACWY, and this one has a 4C. And then there is B. So both are different. And then coming to your hepatitis B A vaccination, which is more common in India, it is given as routine vaccination. Should be given as routine vaccination, but not yet. And it is not at risk but want protection from hepatitis A, then you have to identify the risk factors and decide whether you to give or not. Like if it is a case of unhygienic conditions where small kids are there, pregnant mother, etc., you have to check, and depending on that, you have to give. It is given as 2-dose series of hepatitis A, Haverix, 6 to 12 months apart, or Vacta 6 to 18 months apart, minimum interval of 6 months, or 3-dose series of hepatitis A, B, Trivinix at 0, 1, 6 months, minimum interval of 4 weeks between the doses, 1 to 5 months, or between the doses 2 and 3. These are the ones which are given as hepatitis A. In the special situations like at risk for hepatitis A virus infection, then you give 2-dose series of hepatitis A or 3-dose series of hepatitis A B as told before. In case of chronic liver disease, clotting factor disorders, men who have sex with men, injection or non-injection drug users, homelessness, work with hepatitis A virus in research labs, or non-human primates with hepatitis A infection, or travel in countries with high or intermediate endemic hepatitis A, like that of India, close personal contact with international adoptee. These are all the special conditions where you have to be taking the hepatitis B vaccination. Who are not at risk but want protection. Who are not at risk but want protection from hepatitis B, then identification of risk factors, and depending on that, you have to suggest whether it's required or not. As told before, this is a 2 to 3 dose schedule of hepatitis B, 2-dose series of Hepsalvi B, at least 4 weeks apart, and 2-dose series hepatitis B only applies when 2 doses of Hepsalvi B are used at least 4 weeks apart. If before that the immune recognition and all are not well taken, or 3 doses series of Energerix B or recombinant HB at 0, 1, 6 months, or 3-dose series of hepatitis A, B, Trivenix, or 0, 1, 6 months. This is how you give it during the routine vaccination. Or special situation which tend to be requiring hepatitis B are at risk for hepatitis B virus infection, 2 doses of Hepsalvi B or 3 doses of Energerix B, recombinant HB, and a series of hepatitis B, or 3-dose series of Hep A and B as discussed before. These are the things. This is how you give the vaccination. Hepatitis C virus infection, chronic liver disease like cirrhosis, fatty liver, alcoholic liver disease, autoimmune hepatitis, ALT, AST level greater than the twice upper limit of normal. These are the conditions where you can give hepatitis B vaccination. And also HIV infection you can be giving. This is not a live vaccine, right? It's you can be giving in case of HIV. Then sexual exposure who are at risk can be given. Current or recent injection drug use, percutaneous or mucosal risk for exposure to blood, like that of household contacts of hepatitis B positive patients, residents, and staff of facilities for developmentally disabled person, healthcare and public safety personnel with reasonably anticipated risk for exposure to blood or blood contaminated bodily fluids, hemodialysis, peritoneal dialysis, home dialysis, and pre-dialysis patients, and persons with diabetes mellitus age younger than 60 years are at discretion of the treating clinician. Those at age of 60 years or old. All these are the ones who may require vaccination of hepatitis vaccination. Then incarcerated person, travel in countries with higher or intermediate endemic hepatitis B vaccination, hepatitis B risk. Then we are going for the next vaccination, human papilloma virus vaccination. Usually, if it is a female, you can take it up to 26, and male to up to 21 years. How do you take it? 2 or 3 dose series of hepatitis B vaccine, HPV vaccine, depending on the age at the initial vaccination. Males at age 22, throughout 26 years may be vaccinated based on individual clinical decision. Hepatitis B vaccination routine is recommended at 11 to 12 years, usually at 11 to 12 years, but uh, this was recently introduced vaccine compared to that of previous existing vaccination. So usually the age was up to 11 to 12 years is the recommended age, because you should be vaccinated with HPV before the person becomes sexually active. So depending on either, see, there's a lot of difference between Western community and the Eastern communities when it comes to the age of active sexual life. So depending on that, the 11 to 12 years is put in on the basis of Western community, where the people are early sexually active, so it is given as 11 to 12 years. Before in India, it was comparatively late. Uh, we tend to give it like around 16 to 18 years or around that. There is difference for male and female also. Female can be given up to 26 years as talk. Actually, usually it is 18 to 21, but you can up to 26, but usually 18 to 26 or before they become sexually active. It is required to take the vaccine. Age 15 years or older at the initial vaccination, 3 doses of HPV vaccine at 0, 1 to 2, 6 months is given. Age 9 throughout 14 years at initial vaccination and received 1 dose or 2 doses less than 5 months apart, then 1 dose of HPV vaccine is required. Age 9 through 14 years at initial vaccination and received 2 doses and at least 5 months apart, HPV vaccination complete, no additional doses required. If completed valid vaccination series with an HPV vaccine, no additional doses are needed. Why is it important to give HPV vaccination? So because it is not life-threatening, because it can cause cancers in the long run. So it is required to take HPV vaccination. And special situations like immunocompromising conditions, including HIV infection, throughout the age of 26 years, 3-dose series of HPV vaccine at 0, 1 to 2, 6 months as above. Then you can be given. Men who have sex with men and transgender persons throughout the age of 26 years, 2 or 3-dose series of HPV vaccine depending on the age and initial vaccination as above. Pregnancy through age 26 years, HPV vaccination are not recommended until after pregnancy, and no intervention needed if vaccinated while pregnant, or pregnancy test need not be not needed before vaccination. Next, coming to pneumococcal vaccination. Routine vaccination, age at 65 years or older, immunocompetent, 1 dose of PCV13 if previously did not receive any PCV13, followed by 1 dose of PPSV23 at least 1 year after PCV13 and at least 5 years after the last dose of PPSV23. These are pneumococcal vaccinations. As before, meningococcal, pneumococcal, Haemophilus influenza B, these are the capsulated organisms. So capsulated organisms tend to infect in case of asplenia or splenectomy. So it is preferred to give before splenectomy, and also in elderly. And previously received, those patients who received previously PPSV23 but not PCV13 at the age of 16, 5 years or older, 1 dose PCV13 at least 1 year after PPSV23. When both PCV13 and PPSV23 are indicated, administer PCV13 first. PCV13 and PPSV23 should not be administered during same visit. In the special situations, age 19 through 64 years with chronic medical conditions, chronic heart excluding hypertension, chronic heart diseases excluding hypertension, lung and liver disease, diabetes, alcoholism, suspected smoking. Alcoholism patients are also more prone to um, capsulated organisms infection. And age 19 or older with immunocompromised conditions or acquired immunodeficiency diseases like chronic renal failure, nephrotic syndrome, leukemia, lymphoma, Hodgkin's, generalized malignancy, iatrogenic immunosuppression. Example, drug and radiation therapy, solid organ transplant, multiple myeloma, or anatomical and functional ischemia, including sickle cell and other hemoglobinopathies. Then you give one dose of PCV13 followed by one dose of PPSV23 at least 8 weeks later, and then another dose of PPSV23 at least 5 years after the PPSV23 at age 65 years or older. Then administer one dose of PPSV23 at least 5 years after the most recent PPSV23. Only one dose of PPSV23 is recommended at age of 65 or older. Age 19 years or older with cerebrospinal fluid leak or cochlear implant. Then you give one dose of PCV13 followed by one dose of PPSV23 at least 8 weeks later. At age 65 years or older, administer another dose of PPSV23 and at least 5 years after the PPSV23. Then coming to the next one, varicella vaccine. There is routine vaccination. There is no evidence of immunity to varicella. Then you give two dose series of varicella 4 to 8 weeks apart. If previously did not receive varicella containing vaccine, VAR or MMRV, measles, mumps, rubella vaccine for children. We previously received one dose of varicella containing vaccine. One dose were at least 4 weeks uh, after the first dose is given. In evidence of immunity, US born before 1980, except for pregnant women and healthcare personnel, documentation of 2 doses of varicella containing vaccine at least 4 weeks apart. Diagnosis or verification of history of varicella or herpes zoster by an healthcare provider and lab evidence of immunity or disease is required. And coming to the special situations, pregnancy with when there is no evidence of immunity to varicella, varicella is contraindicated during pregnancy because any live vaccine is contraindicated during pregnancy. But after pregnancy, before discharge, a patient can be vaccinated. So if at all a patient comes during pregnancy telling that his neighbor child or neighbor's child, or if her other child developed a varicella infection, what do? We usually check for the antibody levels of varicella. If at all the antibody, if at all she doesn't, if she remembers that she has varicella infection in her childhood, you need not think about it. It means that she's having immune response against varicella, so you need not give any treatment. But if at all she doesn't remember or if she is not vaccinated, then you can go for the antibody titers, and within 10 days if you know that the antibody titers are there, you need not do anything further. But if antibody titers are not there, then means you can give the varicella immunoglobulin. Okay, not the vaccine, immunoglobulin can be given. Then healthcare personnel with no evidence of immunity to varicella, one dose varicella, if previously received one dose varicella containing vaccine, or 2 dose series of VAR 4 to 8 weeks apart, if previously did not receive any varicella containing vaccine. HIV infection with CD4 count more than 2,200 cells with no evidence of immunity, then consider 2 series of VAR 3 months apart. Based on the individual clinical decision, VAR contraindicated in HIV infection with CD count less than 200. Severe immunocompromised conditions, then VAR is contraindicated. Zoster vaccination. Routine vaccination like age 50 years or older, you can consider 2 dose series of RZV 2 to 6 months apart, minimum interval of 4 weeks, and then repeat dose if administered too soon, regardless of previous herpes zoster or previously received ZBL. Then administer RZV at least 2 months after the ZBL. Age 60 years or older, then you give 2 dose series of RZV 2 to 6 months apart, minimum interval of 4 weeks, and 1 dose of ZBL if not previously vaccinated. If previously vaccinated with ZBL, Then administer RZB at least 2 months after the ZBL, and RZB is preferred over the ZBL. And then coming to the special situation like in pregnancy. Then I hope you are following all of these. Either it is like recombinant vaccine or live vaccine, that is, or live attenuated. Special situation pregnancy. When ZBL is contraindicated, consider delaying RZB until after pregnancy if RZB is otherwise indicated. In case of severely immunocompromised conditions, including HIV infection with CD4 count less than 200, ZBL is contraindicated. Why? It is live. Whereas if you want to recommend something, then you can go for the recombinant RZB under view. So this is the vaccination schedule. As we have discussed before, depending on the age. Now, depending on the comorbidities or depending on the disease state per se, these are the things which are indicated. If a pregnant patient or immunocompromised, excluding HIV infection or HIV infection CD4 count less than 200 or more than 200 with asplenia, complement deficiency, and renal disease with and or hemodialysis, heart or lung disease, alcoholism, chronic liver disease, diabetes, healthcare personnel, men who have sex with men, etc. All these patients require IIV or RIV. They require it as one dose annually. Okay, then live attenuated influenza virus is contraindicated in the first few case scenarios like pregnancy, immunocompromised, CD4 less than 200, asplenia, etc. You should not be given the live attenuated vaccine. And for renal disease, heart disease, alcoholic, chronic liver disease, you should be given under precaution. And diabetes also, whereas healthcare personnel and homosexuals can be given. Then coming to DTP, diphtheria, tetanus, pertussis, you give one dose of TDAP each in pregnancy, or tetanus toxoid you give, and rest of the cases you give one dose and then booster every 10 years. MMR and varicella are contraindicated during pregnancy, immunocompromised, CD4 less than 200. In rest of the cases, you can give 1 or 2 doses depending on the indication. VAR is 2 doses, as we discussed. RZB or ZBL. Both of them. ZBL is live. It is contraindicated in the conditions of pregnancy, immunocompromised, CD4 less than 200. And recombinant, you can delay it in pregnancy, not like you give it at a stretch. You can delay it because you give immunoglobulin can be given instead. Then 2 doses in rest of the condition you give 2 doses at age more than 50 years and 1 dose more than 60 years. And HPV vaccine female you give if they are immunocompromised CD4 less than 200 or 400 more than 200, then you give 3 doses throughout the age through age 26 years, or rest of the age 2 to 3 doses through age 26 years or 21 years male. Homosexuals 2 to 3 doses throughout the age 26 years. And then PCV 13, PPSV 23. In that you give 1 dose of PCV 13, whereas PPSV 23 1 to 3 doses depending on the age and indication. As we discussed before, hepatitis A and B, you give it as 2 to 3 doses depending on the vaccination schedule. And then meningococcal ACWY, you give 1 to 2 doses depending on the indication, and then booster every 5 years if risk remains the same. And meningococcal B is contraindicated, is not given in pregnancy. It can be given in 2 to 3 doses depending on the vaccine and indication and rest of the stages. And Hib usually you give in splenectomy patient and hematopoietic stem cell transplantation patients. You give it as 3 doses or 1 dose in rest of the cases. So this is a thing about adult vaccination. This is comparatively a topic which is not attractive as that of other classes, because this is merely something to remember rather than some mechanisms and all. So you can this is something you can remember only the vaccines, and how is it given is also not so asked at your level. You can just ask what they can just ask you what are the vaccines which can be given in elderly, then you can say all these names, either elderly or in immunocompromised state. These are the vaccines. Just remember these vaccine names and all. It will be helpful to you. So, any doubts? You can give the attendance. If there are no class, I will no doubts regarding this. I will switch it off. I mean, I will leave the chat box. You can put your attendance. If you don't have any doubts,